My name is Andres Cardenas. I'm a physician at Hospital Clinic in Barcelona at the University of Barcelona. And today I have the pleasure of presenting with Lupe Garcia Sao and Pierre Emmanuel Bratu, the wrap up on cirrhosis and complications. It's a great pleasure to have two experts, particularly Dr. Guadalupe Garcia Sao is going to be summarizing some of the highlights of this Digital ILC. And as you all know, she's a world-renowned expert. She's at New Haven, Yale University. And Pierre Emmanuel is a member of the Scientific Committee of EASL, and I'm a member of the Education Committee at EASL. So with further ado, I'm going to start off asking Lucas some questions regarding the papers and the abstracts that were presented at ILC. And first of all, there's a lot of buzz around TIPS and about the definitions and how we need to understand how to define TIPS and the time frame when TIPS is to be placed. You want to expand on that, Lupe?
Sure. So first of all, thank you, Andres and Pierre Emmanuel, and thank EASL and all the help that having invited me to give this webcast for management of cirrhosis and complications. So let's talk about variceal hemorrhage and where TIPS goes. And this caused a lot of buzz on Twitter. So you get the patient, you do the general management measures, then you do the endoscopy. At that time, you do EVL when possible. The normal standard therapy is you continue the AAV vasoactive drug for 2 to 5 days, mostly 5 days. And if there's no bleed, you then do CDIV drug, you start non-selective beta blockers, you do ligation. If the patient rebleeds within these 5 days, then the patient is a candidate for rescue TIPS. We are rescuing the patient because the patient has failed standard therapy, all right? Now, the other way of failing is if the patient continues bleeding despite ligation at the time of endoscopy, or actually there's so much blood that the ligation cannot be performed. This is another form of failure. This patient clearly is also candidate of rescue TIPS, and as a bridge to rescue TIPS, they can get a balloon, they can do whatever you want, but this is rescue TIPS. And the people that mostly fail standard therapy are patients with advanced cirrhosis, child C patients. So this brought up, what if in a patient at a high risk of failure of standard therapy, what if we preemptively put a TIPS in? We put a TIPS in before they fail. And this is the concept of preemptive TIPS or P-TIPS. It used to be called early TIPS because you would put it early on, but it caused major confusion. So we now call it preemptive TIPS. This is TIPS that is placed before the patient fails. And so we're preempting the need of a rescue TIPS because when they bleed again and they get a rescue TIPS, these patients get sicker and sicker and the mortality is very high. Now, in both instances, whether it's rescue TIPS or preemptive TIPS, once you think about TIPS, you have to go and place it early. That is where the term early came. Early means that you're going to do it the moment you thought about TIPS. You have to go down to IR or you go to your interventional hepatologist and tell them you need a TIPS placed, ideally within 24 hours, but all the studies have allowed 24 to 72 hours. So this is the main definition, rescue versus preemptive TIPS. Now, the key is how do we define these patients? And these patients, like I said, P-TIPS will be placed within 24 to 72 hours from admission. And so, oh, I'm sorry.
Lupe, I've got a question. What are these patients with considered at high risk of bleeding?
Correct. So, in studies of rescue TIPS, they were always child C, the sicker patients. In the initial seminal study by Garcia Pagan et al., the multi-center study, they identified child C, 10 to 13 points, because we knew that these are the sicker patients, right? But you exclude 14 and 15 because they're too sick to get a TIPS. They're going to die if you get a TIPS, right? So this is the seminal New England Journal of Medicine paper in 2010. And they also...
one more question, excuse me to interrupt you, but this child C, when is that measured? Because you made it very clear that we have to be careful with early making a difference between rescue and preemptive. This is very clear. You're mentioning high-risk patient, child QC, but is that child QC at admission or 1 or 2 days later? When are you taking this child PUC?
In the studies, they have assessed this at admission. All right, I'll show you in 2 seconds. So in this New England Journal of Medicine paper, they included 2 types of patients: child C, which were the ones that traditionally are the ones that fail, but they also included child B that had active spurting from the barracks at the time of endoscopy. And this has been the controversial. So I think that for child C, we're all convinced, because not only that one, but in their meta-analysis, which is abstract, this one that I discussed in the wrap-up, those patients are clearly the ones that will benefit. So child C, 10 to 13 points, there's no question. The child B group is a little bit more tenuous. So in the individual meta-analysis, which is this one, they found that in addition to having a child B that's sort of a sicker B, child B is 7, 8, and 9 points. So here we're talking only the 8 and 9 point child who had actively endoscopy. So they further sort of like identify these patients a little further by saying now we need scores 8 and 9, all right? But the Chinese group, who only included child B in their trial, they used another way of stratifying these patients, and they used a Cliff AD score that includes markers of bad liver disease. And if the score was more than 48, these were the ones that benefited more from preemptive. So this is out there. This we have to confirm even further. It would be ideal if all the studies will all get together to figure this out.
This is important to know, because it's only about 15 to 20% of patients are actively bleeding at endoscopy with an EVH.
Correct.
So not only B child, but always have in mind they have to document if there's active bleeding or not, because that certainly is going to sway you towards thinking about TIPS or not, even if the patient is not a child C.
Correct. Now, if you look at how these compare to each other, I think that the modified Cliff ID is identifying those that are child B 8 and 9 points. So it's not any child B, it's a sick child B. All right. It's a sicker child B. So, and this is what Emmanuel was asking me, criteria for P-TIPS are usually determined at admission. They're not determined at the time of endoscopy. I mean, theoretically, you're doing the endoscopy pretty soon, right? So they're determined right on when the patient comes. So when the fellows are presenting the case to me, I tell them what is a child of a patient, all right?
But here's the thing, though, even when you think about child score in these patients, you have to also think about candidacy for TIPS. So obviously there are patients that are not candidates, and they have to, really work these patients up. So what's your take on that?
So obviously the not candidates are the ones that do not meet these criteria, right? So never put a P-TIPS in a child A patient. These patients, like I
They're gonna do fine.
They're fine. They're difficult to kill. Do not put a TIPS in them. Child B7, because the 8 and 9 are in this group, which are also healthy, sort of healthy patients with cirrhosis. And then the sickest of the 6, which are the child C 14 to 15 points, they're at a high risk of developing liver failure with TIPS. So those are patients who are not TIPS candidates. So if you think about it, you also have general criteria for TIPS placement, and these are the criteria of the patients that were excluded from these TIPS studies. Old patients, because they're more likely to develop encephalopathy and or heart failure. The child's pure more than 13, so the 14 and 15 points. Recurrent overt encephalopathy without precipitant factors. So this is in the past, all right? You know that the patient comes in again and again with encephalopathy.
Lupe, excuse me to interrupt you, but I think there was an abstract at Digital ILC on hepatic encephalopathy at admission. What was your take on that? Is that a contraindication, hepatic encephalopathy at admission?
So here you go, Pierre Emmanuel. There it is. This is the abstract. These were high-risk patients. So in this study, the high-risk patients were defined as the child B with active bleeding and the child C less than 13 points. And they compared 66 P-TIPS to standard of care. So they did not need recurrent overt encephalopathy, but they had hepatic encephalopathy at admission. When a patient bleeds, that's a precipitant of encephalopathy. So it's almost a given that many of these patients, especially the sicker ones, are going to get encephalopathy with bleeding. So they showed that not only they had a lower mortality, patients that came in with the preemptive TIPS compared to standard of care, they still maintained that improvement in survival. and they had a lower rate of recurrent encephalopathy post-TIPS, so 17 versus 27%. So the message from this as was, you should not fear placing P-TIPS in a patient with HE on admission. All right, so that's when they come in because they're getting HE because they bled, that should not be a deterrent. Now, if they have
then that's very different from recurrent overt
Correct.
encephalopathy, which is chronic and recurrent. That's a completely different concept. So people
Correct.
should really take a good history and look at the medical chart before,
Correct.
you know.
So number
simple
one, they should
things,
take a good
you know,
history.
these things do happen.
Correct. So the other contraindications for TIPS in these studies were a serum creatinine more than 2.5 to 3, sepsis or active infection, and importantly, heart failure, pulmonary hypertension. We've seen this happen a lot. You put a TIPS in, all the blood that is sequestered in splenic circulation now goes to the central circulation, and those get worse. So HCC beyond Milan criteria and complete portal vein thrombosis, although this is now perhaps questionable. But for this, okay, yeah, you want to ask me?
No, so the question here obviously becomes, when you look at this list, then our question is, from a practical point of view, what do you need before you start triggering and thinking about TIPS? What do we need to do with these patients? Obviously, a physical exam and a history is as every patient, but what else do we need?
So we would need a cardiac echo. So if the patient has passed all these initial clinical tests, then you say this patient is a TIPS candidate, go with cardiac echo. And I would get some kind of cross-sectional imaging or even any imaging to make sure they don't have, you know, HCC that's huge or a complete portal vein thrombosis. This could be discussed, I think, currently. There's evidence that portal vein thrombosis, you could actually put a TIPS in and successfully.
Yeah,
so this contraindication is in view of current evidence, I think it's a little less clear.
Yeah, it's a relative contraindication because it depends on the extension of that thrombus and if it goes into the mesenteric or splenic vein, obviously.
Correct.
That's very very clear, Lupe. Thank you very much. I had the occasion to watch the presentation of the Attire study from UK during the late breaker session. You know, the Attire study. This is the study from UK, multicentric, very large study, multicentric, where they tested the normalization of serum albumin levels in patients with acute decompensation of cirrhosis. I found it very interesting, but also kind of contrasting with the results of the ANSWER study published 1 year ago. So what was your interpretation, Lupe, on this study as compared to the previous one by Caraceni and co-authors?
Sure. So thanks for that question. I think the controversy of albumin is huge, and I think so. Let's start with why they planned this study. So this is a Caraceni study. It's a multi-center Italian study. They randomized patients to weekly albumin. They compared to standard therapy, but there was no placebo. So this was an open trial where these patients were coming in weekly and seeing the doctor weekly, versus these patients were seen at longer intervals. So the fact that there was no placebo and that the files were different already biases the study a bit, but they did find an incredible survival benefit. But they also found that weekly albumin was associated with lower rates of hyponatremia, SBP, and hepatorenal syndrome. Very important. So this, and they just have a preprint in Journal of Hepatology that correlate this survival to having high levels of albumin. Now, the second study, but however, there's another study by the Gines group that looked, this is a better designed study in that they had a double placebo for albumin and military. So you're using not only volume expansion, but also vasoconstriction, and that should work better for a patient with refractory ascites. So these were patients with persistent, they both are patients with persistent ascites, okay, despite diuretics. And you can see here that in this study, there were really no differences in survival. And there were no difference in renal failure, in hyponatremia, in bacterial infections, encephalopathy, there were no differences in anything. So here you have, this is in the outpatient setting, okay. Yes.
So two things come to mind with this. One is obviously infections seem to be one of the endpoints of the entire study. And the question is, was there any, information on infections, and what was the signal there?
So let me show you the entire study. So the entire study, so while the two studies that I've shown you are outpatient, their goal was to see if targeting serum albumin during hospitalization, so they try to keep the albumin at 3.5, well, we call it 3.5 milligrams or 35 grams in hospitalized patients with decompensated cirrhosis. And their goal was to see if it was a three primary input: infection, renal dysfunction, and mortality. And so this is what they had. They had a 414, this is a large study, all right, in each arm, and they assessed the outcomes at 14 days or discharge of the patient. And these are the outcomes. The primary outcome, which was a composite and three different endpoints, was not even remotely significantly different. Obviously, the volume of albumin infused was 10 times greater in the albumin group. Infections, like you can see here, they were not different. Renal dysfunction was the only one that had sort of a tendency, as you would expect, right? You're expanding the volume of these very sick patients, but mortality was totally not different. Neither in even 3-month mortality, and this is very important because this is following them out. They were not different. On the other hand, and what is very important is that serious adverse events were significantly greater in the albumin group versus the standard of care group, and cost was clearly higher in the albumin group. And the main adverse events were volume related, pulmonary edema or volume overload.
So two things come to mind here with these studies is that one, you're infusing albumin in long term. These studies were 1.5 years. One of them, the other was a long-term study. And obviously you're basically trying to see if you get a better outcome for your patients in terms of transplant or overall survival. But again, there is the volume issue. And I wanted to focus on this because it seems like the amount of albumin that's being infused in patients with cirrhosis and ascites is different to the amount that's infused for a patient with SBP or a patient that needs therapy for hepatorenal syndrome. So what's your take on volume, and how should we go about, preventing this issue of volume overload?
And I think, I mean, here in my institution, I hate to say this, but they get albumin like you cannot even believe it. The patient sneezes, they get albumin. So thankfully, they restrict the albumin when the patient has more than 3.5, I think. This is when the pharmacy will not provide any more albumin. But patients are going, and we're seeing a lot of volume. We're seeing, even with the SBP criteria, 1.5 grams per kilogram, we're getting a lot of pulmonary edema and volume overload. And in fact, I have data from the prospective terlipressin study show that patients on terlipressin, and this is because terlipressin came with a load of albumin, were more likely to get respiratory failure and or pulmonary edema. And so this, in a way, I think this is a point about albumin use. I think we have to be very careful. In the outpatient setting, they were giving them every week, but I would still surmise that there may be a problem with volume later on. But in the inpatient setting, I think we have to be very careful. And I think I really like this study in that it brings up a cautionary tale as to, volume overload by the overuse of albumin.
Right. So and basically, infections and in particular SBP is something that's pretty clear that albumin is important, and perhaps the amount that we use for HRS needs to be reassessed in terms of how much and how fast you place this, but particularly it's important.
And I would claim also for, the SBP one, so you start with 1.5 grams per kilogram. I mean, I remember a patient at our institution, he was like 300 kilos, right? So he got all the albumin in the state of Connecticut, and next thing we know, he was desaturating. So I mean, I think I agree with the guidelines, and in fact, in our current guidelines, this is the recommendation because this is the only randomized controlled trial that supported the use of albumin in these doses. But I think at 1.1 has to use clinical criteria and modify the guidelines according to.
Yeah, but do remember that the amount of albumin that has been used in these studies was an arbitrary dose chosen by the investigators.
Totally.
And I work at a hospital clinic, and I can tell you that obviously this is an arbitrary dose that we've used for years, but it's not been compared at different doses and and replacements.
And no one is ever going to compare this. You see what I'm
Right.
saying? That study is not going to be replicated. So we have to work with acquired knowledge. And I would say I never use 1.5 gram per kilogram. I just use it in like standard doses in the AM or the PM. So we need to figure out, you know, what are how to monitor in a way this volume expansion that is given when one uses albumin.
Okay, so thank you very much. I think we can say that at least part of the difference between the entire study presented at the Digital ILC and the previous study was that the first one was in an acute decompensation setting and the other in an outpatient setting. And but we understand also that there is still room for further studies to clarify particularly the volume that should be infused into patients. We are speaking about infection, Lupe. I saw during Digital ILC some abstracts on infection. So far, classically, antibiotics in patients with cirrhosis are given, as you mentioned that a few seconds ago, secondary prophylaxis of SBP. Also, you mentioned that previously in the context of bleeding, gastrointestinal bleeding in patients with cirrhosis. There are more debates about the effects in primary prophylaxis to prevent or to decrease survival. What is your opinion about this third indication, Lupe?
Thank you for that question. So this is a table that summarizes the settings in which one uses norfloxacin prophylaxis, antibiotic prophylaxis. In GI hemorrhage, there's a lot of evidence that this prevents all infections. There's a meta-analysis. There's many meta-analyses, but this to me is the best one. Shows infections decreasing and a survival benefit. So there's no question in my mind that GI hemorrhage, yes. In a short term, right, you just use it while the patient is, while the patient is on vasoactive drugs. I am totally fine with that, right?
One quick question, Lupe, in terms of GI hemorrhage, child A patients, what's your take on that?
Yeah, this is great. Andres, my point later on, we're going to mention this actually. Because,
we've talked about this before, but I just want...
It is the sickest patient that is prone to infection. So even in the setting of GI hemorrhage, child A patients do not seem to benefit from norfloxacin prophylaxis or any antibiotic prophylaxis. Okay, so this is it's a retrospective analysis by Punita Tandon, and she clearly shows that the most benefit is seen in child C patients. But because we don't want people to not use prophylaxis in last Baveno,
we sort of go with it, right?
We could not do away with the A patient. But if I had a restricted volume of antibodies, if it's a child A patient, I would probably not use antibiotic prophylaxis in these patients. I agree. It's the sicker patient. Okay, so then the next scenario is the people who have had a previous episode of SBP, and here we have like essentially a GNS study. Bauer is not a randomized study, but you do show that the recurrence is decreased. They stopped the study before they can evaluate survival, so we don't have clear survival benefit, but I think it's reasonable to use it for prior SBP. Problem being that we're now getting these studies are really old and like we're talking 30 years 80s. Old. And at the time when we did not see, most of these infections were from gram-negative. So now we're getting gram-positive SBP, MDR, multi-drug resistant organism causing SBP. So the answer is, if the patient came in with infected with a multi-drug resistant organism, is norfloxacin going to work? I don't know. You know, so the question to that is, we don't know, and I would probably not give them prophylaxis, but that's up to the provider. We go to the next step, which is low protein ascites without any other risk factors. So there's any patient with ascites and cirrhosis that has low protein. And in this, so we're preventing these two trials, and I excluded the ones that mix primary and secondary prophylaxis because I hate that. So first SBP, these were the two trials that were really for primary prophylaxis. This difference is really, this is significant in terms of first SBP, but look at the rate. It's like a really, you're preventing 12% and you're using antibiotics, and without any differences in survival. So as far as I'm concerned, if you don't further subclassify these patients, I would not treat any patient with low protein ascites. Which brings us to the two main studies that actually look at sicker patients. The Fernandez study that looked not only at low protein ascites, but liver and circulatory dysfunction, as I'll show you. And there, in the Shumoho study that looked at child C patients, and they both used norfloxacin, and their endpoints were not infections, but their endpoints were survival. So in terms of infections, none of them showed a difference in infections. These differences in infections without or with prophylaxis were not different. In the Fernandez study, the 3-month was significant, but the 1 year was not. And in the Mojo study, as I'll show you, there was no significance. So this is the Fernandez study, but I think it's very important to show that, in fact, this is survival. They found a significant improvement in survival in norfloxacin. But who were these patients? They were not just any patient with an ascites protein less than 1.5. They also had to have creatinine 1.2, BUN more than 25, or serotonin less than 130. These all are indicative of vasodilatation and of decreased renal perfusion, or they were sick as with a child score more than 9, which is child C patients, and a bilirubin more than 3. So these are the sickest of the sick, and these were the patients that actually benefited. And they also found that you could prevent HRS in these patients. So this makes sense. He identified a group of patients that were at the highest risk of getting an infection, and in them they were. In the Moral study, he first included all child C patients. They found no difference in survival in their primary analysis. They used the log rank test. But in post hoc analysis, now using the grade test, so they use death as a competing event. You can see that now they're down from 291 to, this is a third of the patients in this study. And those who had an ascites fluid purging less than 1.5, they actually saw a survival benefit. This is incidence of death, so much less death in the norfloxacin group. So I think that in a way, if I had to use primary, we're talking primary prophylaxis. So these patients have never had SBP. And for the first thing is they have to have an ascites protein less than 1.5, which the majority of the patients with child C will probably have. But I think that any patient, a child B or an early child C, I would probably not give him prophylaxis. You have to have the sickest of the sick child C. And in Mojoso, like the males were all, the median male was 21 or so. So these are very sick patients. So if these are very sick patients that by some miracle have never had SBP, then I would probably consider them on norfloxacin prophylaxis. And I usually try to do this if the patients, for example, on the transplant list, right? So they're on the top of the transplant list. They've never had SBP. And now if they get an infection, they're going to lose their place in the transplant list. Those are the patients that I would consider primary prophylaxis.
So the question is, with time, do you think the effect of norfloxacin may be affected?
That's an incredibly important question, and I think this paper, unfortunately, I did not have time to comment it in the wrap up. But this is a systematic. This is actually a network meta-analysis, and they looked at all the studies of 12 RCTs of norfloxacin versus placebo in primary prophylaxis, and they looked at it over time. And you can see here, this is the incidence rate ratios. So the ratio initially was huge. So norfloxacin was far better than placebo. But as time goes, this was back like we're talking 20, 30 years ago, right? But as time has gone by, this ratio has been decreasing significantly. And this applied to any fluoroquinolone. So now that we do not have norfloxacin, if we use Cipro, it's the same thing. The efficacy has been decreasing. And I think this is a very important study. So they concluded that there's a reduced efficacy of norfloxacin quinolones in preventing SBP for primary prophylaxis over this time. And one wonders, is this due to increase in multi-drug resistant organisms? So they wrote this study from an Argentinian group that looked at the effect of norfloxacin prophylaxis in the development of MDRO infections. All right, this was a multi-center prospective cohort study, and they found that the most common infection was SVP and urinary tract infection. But in a way, it's a little bit under par. They had 337 places on norfloxacin versus no norfloxacin in 46. But bottom line, you can see that the patients that were on norfloxacin tended to be sicker. But what is clear is that on univariate analysis, there were no differences in the ISO. So what they did is they followed these patients, and the moment they got an infection, that's when we're studying them at one time point when they got the infection. Then they just saw in the patient's medication list whether they were on or off norfloxacin. So you can see here, because this was not significant, and because factors that would allow someone to be on norfloxacin could also be more likely to have MDROs, they did a propensity score. So they did a sort of a multivariate analysis using a propensity score, looking at all these variables. And then they did a weighted logistic regression model. And you'll see here that this is the result. The bottom line, that the odds ratio was not significant, but the odds ratio was 2.8, meaning you have more MDRO with norfloxacin, but the confidence intervals were huge, from 0.6 to 12. So this is an underpowered study, but in a way, you would think that yes, that if you look at just the odds ratio, norfloxacin is more likely to create MDRO. But I think that we cannot really conclude a lot with this study.
So you still think that it favors MDRO?
No. Well, if anything, you would think it favors. It's just that the confidence interval was so wide that you get a P that's not significant, you see?
Obviously, there are problems with using quinolones, and this is certainly one, but obviously they've been using them to prevent complications and prevent new infections. But is there another reason to use antibiotics in patients with cirrhosis and prophylaxis?
Yeah, so you, as you know, bacterial translocation is the main thing that not only leads to infections, but leads to more vasodilatation and more complications that come from this vasodilation, like hepatorenal syndrome. So Fernandez clearly showed that in those very sick patients, they could prevent hepatorenal syndrome. In the bleeders, which are also sick patients, norfloxacin and antibiotic prophylaxis has been shown to lower rebleeding. In all the others, it hasn't been clear. And I have this paper that was also presented at the meeting, but is now published in EPUB, in digestive liver diseases, from Bersigotti's group, that looks at the effect on HVPG. Because if you say there's less bacterial translocation, there's less vasodilatation, less flow, you would lower HVPG. And there are several studies that actually showed that there was some effect on HVPG, but in this meta-analysis, norfloxacin had no effect, rifaximin had no effect. Overall, all of the 5 trials in summary had showed no effect on HVPG. When they looked at serum lipopolysaccharide binding protein, which is a marker of, in a way, inflammation in bacteria going through, they showed that it was significantly decreased with antibiotics, but with a high heterogeneity, so that's not something that's trustworthy. So at the end of the day, we could not find that these reduce HVPG in patients with cirrhosis portal hypertension.
Thank you very much,
Lupe. Thank you.
Yeah, this is really interesting. So, I would like to thank you for giving us your thoughts about all these topics, tips, albumin, antibiotics. So, to me, from what you said, the take-home message is could be 4 tips that we have to make it clear that there are early tips, but early tips should be always early, and discriminate preemptive tips and rescue tips, and make these terms very clear, because there are ideas and acts beyond these words. The other take-home message to me would be that the Child-Pugh score should be taken at admission. This is what you explained us, to decide for the preemptive tips. And finally, importantly, we saw at Digital ILC this important study attesting the fact that hepatic encephalopathy at admission is not a contraindication to preemptive tips placement. So this is the point I saw regarding tips. Regarding albumin, I think that you make it clear that there are 2 different settings: acute decompensation, where we see that there is no added value at ILC by the ATTAIR study of normalizing albumin, and you compare that to the study previously published by the Italian group of Caraceni, showing that there might be an interest of albumin in outpatients undergoing paracentesis. And finally, regarding antibiotics, there is likely no clear association of norfloxacin with multi-drug resistance, but likely further studies are still needed to make that perfectly clear. I would like to thank you, Lupe, and you, Andres, for
Thank you.
sharing this time together and sharing our view on this digital ILC and all the data that have been presented. So thank you very much.
Yeah, thank you.
Thank you very much, Lupe. Thank you, Pierre.
Bye, everybody.